We're going to talk about transcatheter techniques in mitral regurgitation. And you've heard quite a bit today about mitral regurgitation. And it's important to remember that there are really two types. One is the degenerative mitral regurgitation type, and the other one is the functional mitral regurgitation type. And it's important to remember these two types because it makes a difference on the risk and on the approach. And I think Nasser today asked the question to Dr. Lee regarding functional MR in people, let's say, with a dilated ventricle. This is a challenge. So can this technology compete with surgery, knowing that surgery is not ideal for functional MR? So if we want to really think of the two groups, one is what we call degenerative or organic or primary, meaning all of them mean that the problem is intrinsic to the valve itself, to the leaflets. And then you have the functional, or we also refer to it as secondary, meaning the problem is usually not in the valve. The leaflets are structurally normal, but the leak results from poor coaptation because of usually annular dilatation. That is a result of LV dilatation and a change in the LV chamber geometry. You could have, we also talk about ischemic mitral regurgitation or non-ischemic, but now that we've made the differentiation into primary or secondary, ischemic could be primary or secondary. It could be primary or organic, such as with ruptured or ischemic pap muscles, or it could be secondary or functional because of LV chamber dilatation. The non-ischemic may be organic, such as rheumatic, or maybe functional, such as with a dilated cardiomyopathy. So again, this slide is really very important to remember the two concepts. One is the, we called it DMR, or degenerative mitral regurgitation. We also call it organic, we call it primary, and the other group is functional or secondary. Okay, so that we don't get confused with the terminology. So this is an example of what? This is an example of a very degenerative valve, also called primary or organic. You see that this is a very thick leaflet here, even a ruptured cordy right here. Okay? You see is the mouse? ما عم تشوف الماوس okay, now we see it. So this is the ruptured cordy right there. The valve is usually made out of an anterior leaflet and the posterior leaflet, 3 scallops on each. And usually when you have a prolapse of leaflets in the degenerative group, it is ideal for surgical repair when it is a central posterior leaflet prolapse, such as you see here. So it's a central leaflet prolapse in the posterior leaflet, which is usually quite ideal to repair by the surgeon. Now, you've heard today about the clip several times during this day, so I'm not going to elaborate much on the technique, how you clip the two leaflets together, but the concept came from Ottavio Alfieri, who thought of the following problem. Since for the surgeon, the ideal situation is to fix a posterior leaflet prolapse, there are non-ideal situations, such as when there is an anterior leaflet prolapse or bileaflet prolapse or other types of prolapses. And for that, he envisioned and designed the concept of suturing the leaflets together and creating this bilobed orifice, reducing the mitral regurgitation. And this is where the clip idea came from. So the percutaneous mitral valve repair for severe mitral regurgitation is the, for severe in terms of mitral clip, is the most common and the most studied and the most applied technology by far. Over 20,000 patients worldwide have been done so far. The technique requires a learning curve. It is quite challenging, especially like if you have a patient with atrial fibrillation. But you see, for example, here, 3D TEE is quite important. You cross the septum, usually superiorly and posteriorly, so that you can have a reach into the left atrium, left ventricle inflow. And you advance, this is your needle, then you advance your device, you drop down into the ventricle, you catch the two leaflets, you confirm reduction of the mitral regurgitation to hopefully down to 1+, you create your double orifice, and then if everything is fine, then you release your clip. And you can verify this also by your fluoroscopy. In the Everest 1 trial, most of the time one clip was placed, but then with experience, 2 clips is becoming a bit more common than it used to be. Placing 2 clips, of course, this would require quite a bit more time. Now, you've explained pretty well today all the key anatomic eligibility criteria for the clip. And in fact, I can tell you, early on in the Everest trial, when we had our experience, when I was at Emory, in fact, this must have been in the certainly more than 10, 12 years ago when we started with the very first centers into the Everest experience. It was not very easy to identify those patients, only because to satisfy the criteria, and especially the centrally located jet at A2P2 was difficult to identify. So there were many patients with mitral regurgitation, but few would really satisfy the exact criteria of Everest 1 in primary degenerative MR with the exact central leak. But anyway, Everest randomized 279 patients, 2-to-1 randomization, percutaneous versus surgery. But I'll take you straight to the 4-year result of the randomized controlled trial. Again, most of those patients was of the primary degenerative prolapse type MR. At 4 years, the rate of composite endpoint of freedom from death or surgery or 3 to 4+ MR in the intention to treat population was 39, it was about 40% in the percutaneous repair group versus 53% in the surgical group. So it was a little bit more in favor of surgery as an intention to treat, but the p-value was not very significant. Death were similar at 4 years between the two groups. 3 to 4 MR was present in about a quarter of each group at 4-year follow-up. But what's interesting is surgery for mitral valve dysfunction occurred in 20% versus 2%. So 20% in the percutaneous group versus 2% in the surgical group at 1 year, and 24.8% in the percutaneous group versus 5.5% at 4 years. So if you want to summarize that, the best way to think about it is at 4 years, about 17% would have died, about a quarter of them would have had a recurrent mitral regurgitation, and in the percutaneous group, about a quarter of them would have required surgery. So there is quite a bit of events that are happening after you deploy your clip. So this is not, even though for this type of disease, the outcome in terms of death is as good or as bad as surgery, but still you want to do better than that. So patients treated with the percutaneous repair more commonly required surgery to treat residual MR. But it's important to say that after the first year of follow-up, there were few surgeries required after either percutaneous or surgical treatment, and no difference in the prevalence of moderate severe MR and the mortality at 4 years, as I've shown you. Now, Everest was primarily, as I told you, for degenerative MR. But the problem for the cardiologist and the cardiothoracic surgeon is more the functional MR. And the functional MR was better identified in the Access Europe study, which is just a registry, where many more patients were of the low ejection fraction type, as you see here. And much more, 3/4 of the patients had functional MR. You see that the mortality at 1 year was about 18% on the average. There was 4.8% of single leaflet device detachment, usually within the first couple of months, but no embolization of the clip. In this study, actually, about a third required 2 clips. 6.3% underwent a mitral valve surgery within 12 months. 3.4% underwent a second intervention to reduce MR. If you look at the death rate between the functional group and the degenerative group, that was the same at 12 months. So the FDA approved that device for high-risk patients in degenerative MR in 2013, but it has been widely used around the world, especially in Europe. It requires a team, and there is definitely a learning curve with the time of the procedure going down with time. Now, there are other daring percutaneous technologies. Obviously, the mitral valve clip may not be here to stay over the foreseeable, or at least the long-term future. What are other daring percutaneous technologies? There are a zillion of them. In fact, it is much more complex than the story that you've heard with TAVI. That's because the mitral valve apparatus is very complex. So you have all kinds of devices, some that work on the leaflet, some that work on the cordes, some that work within the cardiac coronary sinus, some that work as direct annuloplasty, and you know, the list is endless. Some that work on coaptation edge to edge, and so on and so forth. Now, that's because, as I told you, the mitral valve apparatus is quite complex, and MR is not so simple. We're talking about an apparatus. We're not talking about a valve like the aortic valve. Here you have the leaflets, you have the supporting structures, you have the left ventricle, you have the annulus. And in fact, the mitral valve apparatus physiology is quite complex. Discontinuation of the mitral to ventricular continuity results in maladaptive remodeling and impaired LV performance, and this is important to remember. The mitral valve regulates the flow pattern within the LV, and preservation of the anterior leaflet mobility and asymmetric flow may be associated with better performance. I'm going to talk to you very briefly about 3 that have made some advancements of these technologies that I've shown you. One is the coronary sinus reshaping, whereby you position and adjust and anchor the device in the coronary sinus or great vein to reshape the annulus around the mitral valve and reduce mitral regurgitation. This was a study on the Carilion mitral contour system, which already has obtained CE mark approval in Europe in 2011. 53 patients were enrolled, only 36 were successful, and 17, the device could not be permanently implanted due to some difficulties or compression of the coronary artery. Remember the circumflex artery. That's because the coronary sinus is not always at the level of the annulus. The coronary sinus, about 20% of the time, is not at the level of the annulus. That's why these technologies are not always guaranteed to be successful working through the coronary sinus. Another device is what we call the Valtech Cardioban device, which just received CE mark approval. And this is a complex device. The approach is from the right atrial side. The best way would be to show you a video. So
Valtech introduces Cardioban Transfemoral, a percutaneously implantable adjustable band. The device is introduced through the femoral vein using a transeptal approach. A catheter is advanced all the way to the heart's right atrium and then through the fossa ovalis to the left atrium. A flexible tube is threaded through the catheter, carrying on its tip the implant, which can be steered to reach any point along the annulus. The implant contains an adjustable mechanism which will be used to adjust the band and achieve the best coaptation. The steerable tip is aimed at the anterior commissure under 3D echo guidance. An anchor is used to attach the tip of the implant to the annulus at the anterior trigone. About a dozen anchors are sequentially deployed as the tip is navigated along the annulus towards the posterior commissure, exactly as suturing a standard annuloplasty band during an open heart procedure. As the implant takes its C shape and is firmly anchored to the annulus, it slides off the implantation tube. The tube is pulled out. A thin guide wire is left in place and connected to the adjustment mechanism. An adjustment tool is then inserted through the catheter and threaded on the guide wire. It is attached to the adjustment mechanism that is located on the band. By turning a knob, the implant is adjusted and the annulus is reshaped. This is performed under echo and fluoroscopy to minimize residual MR. Once optimized, the handle and guide wire are detached from the implant and removed, completing a fully percutaneous annuloplasty procedure. Without missing a heartbeat, Cardioban by Valtech.
So the here you see the examples of those anchors by fluoroscopy. There are many of them. They're all screw-likes, and they're going to stay there forever, so it's a bit scary when you look at them. This is a study that was just presented at the TCT of 40 high-risk patients, whereby the acute procedural success with this Cardioban device to reduce acute MR to less than 2% was achieved in 92%, so that was quite impressive despite how complex this is, and it improved the mitral regurgitation grade and the quality of life. Another device that is going to soon get CE mark approval is the direct annular plication device. This one you have to come from the aorta down the left ventricle and up into the annular of the mitral valve and deploy pledgets from below. And this is how it works.
The Mitraline system, a breakthrough in mitral valve repair. A weakened heart may become enlarged, causing the left ventricle to dilate and mitral regurgitation to occur. The Mitraline system repairs functional mitral regurgitation with standard interventional cardiology techniques. Mitraline's minimally invasive percutaneous procedure is deployed using a system of catheters and wires. A guide catheter is delivered through the aortic valve and placed on the posterior side of the left ventricle. Echocardiography is used to confirm wire placement in the mitral annulus. A second wire is delivered through a double lumen Biden catheter, followed by the pledget catheter, which delivers the pledgets across the mitral annulus. The catheter extrudes half the pledget on the atrial side, then is cinched. The ventricular side is extruded and cinched while the catheter is removed. The delivery of the second pledget follows the same steps. The pledgets are then plicated or pulled together. Once the plication is confirmed, a stainless steel lock is deployed, securing the pledgets in place. When the same steps are followed on the opposite side of the annulus, the procedure is complete. With the Mitraline system, the circumference of the annulus is reduced, relieving the symptoms of regurgitation while preserving future clinical options for patients.
So this is also another form of annuloplasty. Again, I've showed you the ones that are either CE mark approved or getting CE mark approval. Mitraline Transcatheter system, 51 patients also were studied. 30-day rates of all-cause mortality was 2.8%. There was 12% mortality at 6 months and significant reduction in all echocardiographic parameters. This is how the pledgets look by TEE. And finally, transcatheter mitral valve implantation. This is probably going to be the way to go if the technology is going to refine itself enough to become user-friendly, because for right now, there is no perfect technology for that. There are many, many valves on the market, some in preclinical, some in first-in-man, some in... They're all very, very early in their design. So look how many there are, quite a bit. And this is my last slide, just to kind of tell you, for example, what are the expected advantages or disadvantages of the tricuspid, of the transcatheter valve implantation versus the repair. The implantation, the advantages, if the technology becomes quite refined, it may become simple compared to the difficult technology that I showed you in those videos. It may be more versatile and it may give you more predictable result. However, the challenges are that the mitral valve structure is a very dynamic structure. When you try to position the valve, it's even more dynamic than the next door aortic valve. It has an asymmetric anatomy. The deliverability is not easy. You would have to come either from the transeptal approach or from the retrograde aortic approach, both of which have acute angles to them, different than when you do a TAVI. And if you were to come from the apex of the heart, especially if you want to do functional mitral regurgitation, the ventricle is usually not friendly. It's dilated. There is more problems going through the apex than you would if you were to do a transapical TAVI, for example. Fixation of the valve is not going to be easy because the radial strength alone of the implant is not going to be enough to anchor. You need something to anchor it to, and that's why there are some designs of creating an anchor first and then implanting the valve. And then there is possibly the need for oral anticoagulation. And of course, there is always that need, the risk of LVOT or coronary sinus or left circumflex obstruction. And of course, there is, because of the valve is asymmetric, there is the risk of paravalvular leak. So I hope I gave you sort of an idea about what's going on. You've noticed that this is a technology that has a long way to go, and it's much more complex than the TAVI technology. But like everything else, I think in the future, things are going to be slowly perfected. Thank you very much.